Great, great. All right. Hey, we're live for EMS Challenge at in Helena Fire. Thanks for having us out here today, guys. Really appreciate it. So great turnout. We got two docs speaking today, Dr. Washington, one of our senior residents, and then Dr. Sullivan. Just a couple of updates. In 2 weeks, we're at Trustful Fire and Rescue. I know research coming up pretty soon. A lot of folks are using the YouTube channel. If you're having issues getting your certificate from the YouTube channel, you need to email certificates@emschallenge.org. Correct? Yeah. And that we can take care of that. And of note, on the YouTube channel, we have pulled off anything before this cycle research you can't get Con Ed for. You can watch the videos that are on there, but we only can give credit for the things in the past 2 years. So just FYI. So great. All right, we'll get started. And Dr. Washington, it's all you, sir.
I'm Andrew Washington, one of the second-year residents, going to be talking about pediatric cardiac arrest. We'll talk about some other related topics as well, some specific like toxidrome stuff that's a little less algorithmic and a little more nuanced. Hopefully there's some recognition of this character up here. We'll hopefully not in the sim lab portion of today have any recreations of this, but no disclosures here. So objectives, we're going to briefly talk about the neonatal resuscitation pathway. That's not the topic of what I put together today, but we'll briefly touch on it. The topic was pediatric cardiac arrest. So you can make the argument that's more infant cardiac arrest, which I would agree. We'll talk about it briefly, not ad nauseum. We're going to talk about the difference in a pediatric airway and adult airway, anatomy, some of the specifics about intubation, and some of the considerations about how airway management can differ from adults to kids. And then the meat of the lecture will be talking about the AHA guidelines regarding pediatric arrest as well as ACLS for pediatric patients, which is known as PALS, I should say, not ACLS. We'll talk about some specific overdoses, some specific toxidromes, kind of all in the context of if untreated will progress to cardiac arrest, which is kind of how I made the link to be able to talk about that. And then very briefly because this is not super pertinent for y'all's pre-hospital care, unless you get ROSC before you even get there, in which case post-arrest care is beginning as my job starts and y'all's is ending. So not a lot of interaction for y'all, or honestly for me either, will be post-arrest care. A lot of that's ICU level or on the floor, but we'll briefly talk about it. So pediatric cardiac arrest should feel a lot like this, dumpster fire. The scenarios I've been in are even like less of a dumpster fire than I imagine what y'all walk into, because when I get these patients, y'all at least already generally have access. Y'all have got a story. Y'all been running the code for a few minutes. Y'all walk into the scene with absolutely no information and have to try and get something coordinated to hand off to us in the ER. The purpose of this talk is to hopefully get us to a point where this is how we feel when we get the call for a pediatric cardiac arrest. With the knowledge that it's probably going to end up something like this. Low quality picture, but we all can see this, and we've all been in the scenario that creates this. And no matter how much we want it to be this, it's always going to end up looking like this. So any discussion of cardiac arrest, I feel, would be incomplete without H's and T's. Pretty simple stuff. We'll kind of go through a bit the physiology. This is not specific to pediatric arrest. This is just cardiac arrest in general. So H's and T's, if you don't know, are referencing a mnemonic to help you remember what are some reasons, reversible reasons for cardiac arrest that you may can intervene on. So the first one would be hypovolemia, pretty straightforward. There's not enough in the tank, engine's not going to work. This is severe dehydration, hemorrhagic shock could go under this. Hypoxia, this will be especially pertinent for today's talk about pediatric patients, as we'll discuss later. The primary etiology for arrest in pediatric patients is more respiratory failure, whereas in adults it's primarily a cardiac event causing cardiac arrest. So we'll discuss a lot of hypoxia today. So that the acronym is cute and complete, they said hydrogen ion. It's really denoting a state of acidosis here. This can be achieved through many mechanisms of illness. Hypoglycemia, personal favorite of mine. It's one of the most easily correctable, quickly changing physical exam type findings that you can have. You can have someone who essentially looks dead and is on the brink of death, or look like they're having a stroke. give them what is the equivalent of a Snickers bar, and then they're back to normal and ready to leave before you've got discharge papers ready. So this one's really satisfying. Hypo and hyper K, I would argue that with the exception of the dehydrated states, for the Birmingham population, almost every other person seems to be on dialysis, and so there's a lot of hyper K that we see in these populations. Down to the T's, tension pneumothorax causing a tamponade physiology through mediastinal shift and compression of the outflow tract of the heart. This can obviously be relieved with needle decompression, which ideally would fix a lot of your physiology there. Tamponade as well could be referencing pericardial effusion from like a blood collection or other fluid collection. Toxins is an exceptionally large category. We'll go into some of these at the end, but by no means an exhaustive list. And these are generally very hard to pick up, especially once the patient is transferred from the scene to us, because now I know nothing about the HPI except for what y'all are able to tell me. And then thrombosis, cardiac being an MI, and then pulmonary being a large PTE causing outflow tract obstruction or right-sided heart failure. So these are all within some realm of possibility reversible causes. I would argue that a PTE or an MI generally is not anything that you're going to be able to reverse or fix in the field. Some of the toxins you potentially could, but almost everything else on here you can at least go ahead and begin addressing, maybe not so much the acidosis. For today's talk, so these definitions vary and it's super confusing. Depends on who you ask, if it's AHA or American Academy of Pediatrics, but for today's talk, these are our definitions. So neonates, which we're going to spend the least amount of time on, these are babies less than 1. And so likely there will be 2 scenarios in which, or at least in my mind, for the sake of this talk, that we would be interested in even talking about this. One is I just delivered my baby and then you rang my doorbell because I called you as I was pushing and there's a baby that doesn't look good. The other one would be precipitous delivery in the back of your truck, or the other one would be I had a baby and I brought him in and I'm in the ER, or I've pulled up to your fire department and this baby doesn't look well. And that is covered by the NRP, which we'll briefly cover. Otherwise, here's how we'll define an infant and a child and adolescent for the rest of this 30 minutes. So here is the neonatal resuscitation algorithm from the AHA and Academy of Pediatrics. We're not going to go through all of this. I show it for completeness sake, and a lot of this we will kind of cover the pertinence on this slide. So NRP key takeaways, by going through that algorithm, these are the things I think are most important and like actionable things for you to know and for me to know, being pre-hospital and then initial receiving provider. When a baby looks bad, warm, dry, and stimulate. And you're actually going to do that even if the baby looks good, but especially if the baby looks bad. So warm, cover them in blankets, wipe some of that stuff off because it'll cause heat loss. Dry them off real good, and then stimulate, meaning kind of a brisk rub on the back or on the belly. Suctioning through the nose, not so much deep suctioning through the mouth anymore is recommended. If anybody's had babies and cut the cord at the hospital, you know they don't want you to do that immediately. There's some benefits to the pediatric patients for delaying cord clamping. But if a kid needs resuscitation, that will trump cord clamping in that scenario. So it's either you will start your resuscitation with a child still attached to mom, although it usually takes longer than a minute to kind of assess whether or not this child's going to really need the full gambit of resuscitation. Otherwise, you're just going to go ahead and cut cord. So it's not something we'll worry about. Oxygen saturation, I'll jump back one slide. If you notice the box in the bottom right, this is 2 minutes up to 10 minutes from delivery, okay? So this is obviously not just your normal neonate and starting at some arbitrary time 0, but in the event of precipitous delivery, you're not even expected, even if you are providing the most appropriate resuscitation ever, and even in a healthy baby, you're not expected to see oxygen saturations in the 90s until 10 minutes after birth. So in other words, you've got very little information to go off of in a neonate, with the exception of what I'll talk about here in a minute, heart rate, and then what do they look like on exam. Those are really the only things you get that the neonate's going to give you to say, hey, I need help or not. So pertinent numbers to know for the heart rate is 60. So a neonate with a heart rate less than 60, they need compressions. You need to start the NRP algorithm. If they have a heart rate less than 100 and their breathing pattern is less than robust or abnormal in any manner, or they look unwell, you need to start compressions and start algorithmic care. So 60 and 100 are your numbers to know. Don't worry about APGAR scores, all that kind of stuff. That's helpful for an OB or a pediatrician, but means nothing to y'all, means nothing to me. I don't even know how to APGAR score, to be honest. What you need to worry about is, does this baby look well and what is their heart rate? Compression to ventilation ratio 3 to 1. It's all over the chart. UVCs, I don't think that's super pertinent for pre-hospital. More likely your access on these babies are going to be IOs. And then hypovolemia and pneumothorax are the two most common reversible causes from the H's and T's identified in the neonate population. And that's all we'll say about that one. Maybe. All right. So as we have kind of touched on a little bit now, we're leaving infants. We're not going to talk about infants anymore. CAB instead of ABC. So this is a compressions prioritized situation, a pediatric cardiac arrest. This is so that we can prioritize the blood itself circulating around the heart. How often is this? There's 27,000 reported, at least, pediatric arrest cases per year, but 20,000 of those are happening in ICU settings in the ER. Not really our concern here today. We're talking about the 7,000 that happen at a home or in a public place. The stats here are very discouraging. I put them in here to kind of let you know that when you arrive to the scene of an arresting child, you're fighting a losing battle. The numbers are not in your favor, even if you do everything right. So the numbers they give is in an infant population, only 6% are going to make it to the hospital and then survive to a point of discharge. Modest improvement in adolescents, up to around 15%. But an even smaller number of those, if they make it to the point where they go home, even a smaller amount of those are going to be neurologically at the baseline they were before the arrest. So in other words, even if you get them back and they make it to discharge, they're not going home the same. These are likely going to be kids that now require full-time care, full-time support. As mentioned earlier, a big focus of the talk is how arrest physiology differs. For kids, it's generally like an airway problem, respiratory failure, or some type of undifferentiated shock, whereas in adults, it's going to be more a cardiac issue or trauma, of course. All right, so very briefly, because y'all do this way better than I do, because I've never had to do this. Assess for scene safety, obviously. I have a personal interest in actually getting history from y'all. I see a lot of times y'all bring us patients and we care about vital signs and what meds did you give and what fluids did you give, and then y'all are quickly dismissed. Hopefully people say thanks. But a lot of times y'all have a ton of information that we're not ever going to get another chance to get. And so in a scenario, maybe not an arrest scenario, but in another scenario in which you can say, hey, I was worried about this on the scene, or somebody said this, or I got this brief history from mom or dad or bystander, that's super helpful to us because we will essentially get no other history once you leave. What you see on the scene is super helpful as well. I would rather be biased to be concerned about something than not know about it at all. So if the house looks like there's probably drug paraphernalia around and things feel sketchy, or the parents there feel less than trustworthy, that's helpful for me to know. And there's no solid evidence that you have to prove any of this, but again, it's helpful for us, a few hours down the road when we're trying to figure out what happened. If you can, talk to the bystanders, get some history from family or friends if they're there. The big emphasis here is do not spend longer than 10 seconds trying to decide whether or not you need to intervene on a kid that looks sick. So if you're coming up on 10 seconds of do I feel a pulse, do I not feel a pulse, and the kid is, not vigorous or has a strange breathing pattern, you need to go ahead and call for help and start this whole algorithmic care. Don't waste more than 10 seconds. There are some scenarios in which we won't cover this too much further than this, that there will be a pulse, it'll be slow, but chest compressions will still be needed. We've covered one scenario, that was the neonatal resuscitation. Again, heart rate less than 60. Generally, you're needing to provide compressions because they're in a low flow state. They have a heartbeat, but it's not adequate for perfusion. They're essentially ischemic globally, and so you need to provide compressions to increase their their output. Some airway considerations compared to adults, kids can be bagged generally a lot longer and a lot more effectively. There's not a huge rush to get a definitive airway in place. And when I say definitive airway, I mean an ET tube for today. We could debate later if an iGel is definitive or not, but for today, an ET tube is definitive. The ventilation, whether it come from a bag mask or through an iGel or through an ET tube, if that's what you get on scene, is a lot more important and more emphasized in the pediatric population than adults, again, because their etiology of arrest is probably related to a ventilatory or oxygenation problem. Not a ton of data on foreign body obstructions. There are a few algorithms we'll run through here. I would say personally, I would like to think if I'm on scene, I'm going to do a quick oropharyngeal exam. Just open the mouth and look and see if there's a yellow Lego you can grab or a grape you can grab before you put a bag mask on and shove it further into the lungs. I think it's a reasonable thing to do, and it should only take maybe 2 seconds. As long as it's not delaying chest compressions, I think this is a reasonable recommendation. There is no evidence behind point 4 here. In a drowning scenario, maybe some benefit to provide abdominal or back thrust. This is, if you're about to bag someone for the 20-minute drive to the hospital, it would be helpful to empty the airway or empty the stomach as much as you can. But again, the literature is very clear on the fact, do not delay compressions for any of these interventions. But if it's a scenario where someone else can start compressions and you can check an oropharynx exam, or you can pull a kid out of a body of water, provide some back thrust and abdominal thrust while you're getting them laid down, I think that's very reasonable, and it may solve an issue here if you find a forebody. Nasal trumpets, LMAs, eye gels, these can all be used in pediatric population. How's the airway different? The larynx is a much shorter difference from the opening of the mouth than in adults, and then it's a lot more anterior. Also, the epiglottis is not shaped like adults, so adults have almost like a perfect circle epiglottis as your target. Kids are going to look a little more like an omega shape or like an oval. And so this creates usually a situation where it's just a little bit harder to pass an ET tube because the transverse diameter is smaller. So for this reason, we end up using a straight blade a lot of the times in the hospital for intubation instead of a curved. There's a formula here for tube sizing. I would say lay out probably 4 or 5 different tubes, because as soon as you get a view, just start trying to pass and just get in what passes. There's some other formulas that are a little easier to memorize. That's not something I think in the moment I'm going to be able to remember. I'm probably going to rely on a Broslow or just start seeing what tubes fit. And then proportionally, they have larger heads. Kids have larger heads, larger tongues. You're not going to need to grab under the occiput and provide that sniffing position near as much, and actually too much of that will hurt your view. Quick note on foreign body, since we talked about it a bit. The 2025 guidelines came out a few months ago, removed the suggestion for abdominal thrusts from infants. It's now back thrusts, back blows, and chest thrusts. Sorry, it's kind of a mouthful there. I don't know why necessarily they removed the abdominal thrust recommendation. I would theorize that likely there was some harm caused by people maybe too excitedly performing abdominal thrust and it causing diaphragm injury or lung injury. But not sure. For children, though, there's no difference in the prior recommendations. It's still 5 back blows and abdominal thrust. Just infants do not get abdominal thrust. It's chest and back. We've kind of talked about it. No one would recommend a blind finger sweep, but if there's, like I said, if you can see a foreign body and you feel like you can get 2 fingers in there to get it, or a small clamp or something like that, I think it's reasonable. Here's the algorithm for the infant foreign body. We really kind of talked about all this. The only thing to highlight here is the second box, top right. So what are signs of severe foreign body obstruction? If you've got your own kid and you've ever seen him choke in the high chair, it's quite alarming. A lot of times, though, they're really quiet. They can have some color change, real dry cough, real weak cough, not really able to cry or talk. And then you're going to perform the back blows and chest thrusts either until the Lego shoots out, hot dog flies across the room, or the child becomes unresponsive. And at that point, you're now running an arrest situation. This is the exact same chart, except top left, that's for children. This is for infants. The only difference is here in this box. Kids get abdominal thrusts, infants don't. That is a big takeaway from this algorithm. Very short word on LVADs, because that's not necessarily in the scope of this talk, and it's not something I spent a ton of time preparing on. But it's still a common question for us as residents. When do we do chest compressions on an LVAD patient? And because this is Birmingham, you will at some point probably see pediatric patients with LVADs in place. They'll likely be adolescent population. The short and skinny of this whole algorithm is, are they perfusing? So don't forget, but maybe for a second when deciding to start and arrest algorithm care, just forget that they have an LVAD, and are they perfusing? Because in theory, if the LVAD's working, they should be perfusing. They can be unconscious for another reason. People with LVADs can have strokes and be unconscious. They can be drunk and be unconscious. But if they are cold distally, and again, they're not going to have palpable pulses at baseline, but if they're cold distally and look as if they're not perfusing, then perform chest compressions on these people. Don't let the LVAD stop you from what you would normally do. All right, so a little bit of the boilerplate stuff here. All right, we're good. So 2025 guidelines came out about 6 months ago. We've already talked about one major change. It was no abdominal thrust in an infant. Another big change was they no longer are suggesting the two-finger chest compression technique for infants. So previously it was taught, you could put generally index, middle finger right over the breastbone and compress like this, versus some people would just do the palm of the hand. And probably what is most preferred is head of the bed, two thumb encircling technique. So you can either do the one hand or two thumbs. No longer do they want anybody trying the two fingers. I don't necessarily know why, but that is what they want us to not do. Ventilation. So single rescuer, it's on the next few slides. Obviously not really pertinent to y'all unless you run up on a situation off duty and you are truly alone, but I would say most of the time y'all shouldn't be single rescuer situation in these types. So y'all will be looking at a 15-2. Ferg let me know though that the teaching kind of colloquially here is just continuous compressions. And I agree. I don't see how there would be any benefit or how it'd be any detriment. And honestly, it's a lot easier to remember than these ratios that change based on, is the kid 1 month, or are they 2 years old? Is it you and a buddy? Is it just you? Just continuous compressions and then breaths generally every 2 to 3 seconds. And that recommendation is from the infants through the children through the adolescents. Okay. So we'll run through these slides kind of quick because what I'm saying here is continuous compressions from one person, breaths every 2 to 3 seconds from another. For children, you can do the one hand or the two thumb if they're small enough. And then as you progress to the adults, we'll come back to those, or the adolescents, generally you're going to be using just a classic two-hand technique unless they're really small. You feel like you just need one hand being adequate. These slides here are just this is the algorithm for pediatric single rescuer BLS. We're not going to really cover this much because that hopefully is not the scenario you're in. And then here's your 2 or more providers. Again, this is not necessarily something that we're going to run through step by step. We already know all this stuff. I'll just again point out, because there's a couple key numbers to know from this talk, again point out that for infants to puberty, heart rate less than 60 and they look like they are dying, then they are clinically dying. So go ahead and continue chest compressions, okay? So the big heart rate numbers are 60 and 100, especially for deciding algorithmic care or not. Otherwise, we've talked about, or we'll talk about all this stuff. Defibrillation. So what rhythms do we defibrillate? How much power do we use? We will defibrillate VFib and pulseless VTAC. We're talking about kids here, so everything unfortunately is weight-based, even the electricity that you're going to deliver for defibrillation. Here are your doses. It's 2 joules per kilogram, first shock, and then any subsequent defibrillation, you're going to just double to 4 joules per kilogram. There are very, very few scenarios in which the AHA recommends doing anything before chest compressions. One of those exceptions, though, is placing an AED. So if you arrive to a scene and you've already decided in your mind, this kid needs full care, we're going to be doing compressions. If there is an AED nearby and you are alone, it is appropriate and acceptable for you to place the AED and delay compressions. Obviously, if there's somebody else, then I would hop on the chest and start compressions and have someone else start unpacking my AED and slapping pads on. I failed to include a slide. I just realized, I'm sorry. I failed to include a slide here of pad placement for pediatrics, but the short of it is put one on the front, put one on the back, overlying the left side of the chest. For adults, a lot of times we get the pad placement where it's left anterior chest and kind of left posterior mid-axillary line. For kids, just go anterior posterior, and that's all the way from infants to adolescents. Just for a quick review, here's a VFib rhythm. Here's an example of pulseless VTAC. Something I noticed in SimLab the other day, working with some of us, was a confusion with when is it pulseless VTAC and when is it me providing compressions and the readout on the Zoll or the Life Pack. So I know there's some delay in simulation, but in real life, make sure you adequately examine the rhythm that is native to the patient. In other words, give enough time off the chest to see what the rhythm is, and make sure you're not stopping for a second and seeing how well your buddy was doing compressions and be like, oh crap, that's VTAC. Give it a few seconds and see what they're actually going to do. There should be a noticeable difference in a VTAC, a true VTAC rhythm, a VFib rhythm, and then what the monitor is going to generate when someone's doing good compressions. All right, so this is the PALS algorithm, the Pediatric Advanced Life Support algorithm. It is very similar to what we've already gone over, except this adds in the code drugs and starts talking about capnography. So we'll walk through each side of this and then go into some detail about some toxidromes, and then we'll be done. Any questions so far? Y'all good? Good. All right, so let's say you arrive to the scene. We can just make it up. It's 4-year-old, just has had really bad asthma for the last few days, progressively worsening, says mom, eventually became super distressed and appeared in extremis, and then syncopized. When you get there, heart rate is maybe 20 or 30 beats per minute. So we know that that's less than 60, so we're going to go ahead and start compressions. This kid looks unwell. Your colleagues there, they're going to start bagging for you, and then you're delivering continuous chest compressions. Hopefully at some point you brought your AED in and put that on, maybe even before you started chest compressions. And so here you're at your first split. So put the AED on, get your first rhythm check. Rhythm is not shockable. We're going to go down the right side of the algorithm. What do? You continue compressions and give epinephrine. You're going to do that, giving epinephrine every 3 to 5 minutes, and then rhythm checking. The rhythm remains not shockable. You really don't have a lot of options. You're going to continue to give epi, you're going to continue to give chest compressions, and then mentally be running through your H's and T's about, are there any of these I can check? Is there any I can rule out? And if I find one that's positive, what can I do to fix it? Okay, so that's really all you can do if you don't get a shockable rhythm. It's compressions, epi, H's and T's. Say you get a shockable rhythm, kid's in VFib, deliver a shock at 2 joules per kilogram first time. Say it works. Then you can run down this side. You're still giving epi. You're still doing compressions, even after a defibrillation. So that's the kind of a key point here is, say you get an obvious VFib reading on the monitor, you deliver an appropriate 2 joules per kilogram. A lot of people will be tempted to initially pulse check at that point and delay compressions, but that is incorrect. They want you to immediately resume chest compressions after defibrillation. For 2 reasons. One, you make the safe assumption that defibrillation did not work and they are likely still in a non-perfusing rhythm. The other assumption, more physiologic here, is that even if you've restored a regular rhythm, the heart is so stunned from the fact that it was just dead that the relative cardiac output is minimum to none. So while they're in a normal rhythm, it's not a perfusing normal rhythm yet. They're going to need a few minutes for some cardiac recovery and to actually start pushing blood that's been sitting or artificially being pushed from your compressions. So you're still going to continue CPR for 2 more minutes before you pulse check, even after a defibrillation. I would argue that after your second defibrillation is when you need to start thinking about something other than epi. So that's when you get into your antidysrhythmics, amiodarone, lidocaine. And then all the time in the back of your head, you're running through H's and T's. Is there anything I can intervene on to stop this arrest? So some of the co-drugs, this honestly is a little bit chaotic. So I kind of broke it up into pieces from here on. Epinephrine, again, this is PEDS world, so everything is milligram per kilogram or concentration per kilogram. All of the co-drugs, though, can be given IV or IO. Some of these can even be given through an ET tube, but again, we're not so focused on definitive airway management, so I'm not going to talk about that. And the dosing is very strange. So for epi, it's 0.01 mg per kg of your 0.1 concentration. Again, IV and IO, same dose for either route. Amiodarone here is 5 mg per kg and bolus that up to 3 times. There is a max on amio. I think it's 300 milligrams. And then lidocaine, IV or IO, 1 milligram per kilogram. To make your decision between amiodarone and lidocaine, the AHA doesn't have any specific suggestions here. They just tell you amio or lidocaine. I'd say just from brief experience, I've seen amiodarone more than lidocaine. I don't know if it's for ease of dosing, just based on the fact that it's a 5 mg per kg versus 1. Like both of those are pretty simple. There's probably some data to suggest which one is more efficacious, but from anecdotal experience, amiodarone is generally more used. Other potentially helpful drugs, again, we're kind of moving into some of the toxidromes and addressing the H's and T's. Bicarb, honestly, not something I think that has a pre-hospital place to be done. You can actually kind of just forget that's even there. Glucose, obviously, we talked about that a bit, and then Narcan or naloxone. These would be potentially helpful. We talked about in SIM yesterday, giving glucose and giving Narcan are pretty much decisions that can be made with minimal suspicion that also have minimal downside. So running someone's sugar from 200 to 400 for a few minutes while they're in cardiac arrest is not going to be an issue. And giving someone Narcan when they don't actually need it, unless they're a methadone patient, is really not going to have any downside either. So these are pretty safe interventions. If you have any suspicion at all that an opiate ingestion or the low sugar is playing a part in this arrest, I would give these pre-hospital pretty liberally. All right, we're going to go over 3 toxidromes or overdoses. and then we'll run through a couple questions. So opiates, can't really have a talk about anything without talking about opiates these days. From 2019 to 2020, there was a 12% increase in the reported cases of pediatric overdoses. I'll make the point now that we send home a lot of people with Narcan kits, adults, as well as teenagers who come in with long bone fractures or go home after surgery and stuff. They go home with Narcan kits now, especially from children's. And so I would guess that there are probably more pediatric ingestions that don't make it to the hospital because they get Narcan at home, either from another teenager their age who recognize it or from a parent who doesn't want to have to take their child to the hospital after they've gotten into their oxycodone. Also, there are many times where pediatric arrests are at the time not known to be, but are later found out to be opiate overdoses. So there's a good chance that the actual number is greater than what's reported in the literature. There's a biphasic pattern to opiate ingestion in pediatric population less than 5 years old. Generally, this is obviously unintentional, and these are usually polypharmaceutical ingestions. A kid gets into medicine and just doesn't, obviously they don't know. All of it looks like candy, so they start chewing it up until it tastes bad. And then the older kids, the adolescents, these are more so suicidal intent, self-harm, or attention-seeking behavior. They're doing this on purpose. Generally know what they're taking. Again, there's the push for prioritizing algorithmic care and chest compressions over all these other adjuncts. And I want to make it very clear here that trying to fumble around in a bag and find your Narcan that's at the bottom of the bag versus when you could be doing chest compressions is not suggested. So they want you to prioritize compressions over Narcan. Again, they're very clear with this. Narcan has no proven benefit once cardiac arrest has started. So you're not going to, we talk about the H's and T's. I would say this falls under hypoxia because they've progressively just quit breathing and then arrested. But once someone has entered cardiac arrest and you're on their chest, Narcan's not going to wake them up enough to reverse the arrest. So there's kind of this golden hour, if you will, that exists for when is Narcan administration actually helpful. And it's unfortunately immediately pre-arrest. It's can you prevent them from progressing to the point of complete collapse? Once it's already happened, Narcan, probably should still be given, but certainly wouldn't prioritize it. Fentanyl, methadone, and heroin, for whatever reason, are the highest risk, or they have the highest mortality when those are the opiate-based ingestions. And then again, naloxone dosing, it's 0.01 mg per kg. You can give this IVIM or even sub-Q. And then second dose, which again, if I'm convinced enough to give one dose, I'd be convinced enough to give two. Second dose is a tenfold increase. It's 0.1 mg per kg instead of 0.01. You can repeat this every 2 to 3 minutes. And then keep in mind that my 4-year-old is going to respond a lot, more dramatically to, 5 milligrams of oxy as opposed to how one of us would. So just from a pure concentration, they're going to require larger amounts of Narcan than adults will because an Oxy 5 is way more powerful to them than it is to somebody else. Not that I'm expecting anyone to overdose from an Oxy 5, but for the sake of what's probably commonly in a household here. Clonidine. This one comes up, or I bring this one up because unless someone tells you, hey, there's clonidine in the house, we found this kid in a bottle of clonidine, this is going to look like an opiate overdose, and we're all going to call it an opiate overdose, probably until somebody orders some expensive tox screen at Children's in the PICU and can tell you otherwise. So these kids, they're going to look very similar. This is different. It's not a opioid alpha receptor antagonist or agonist. This is an alpha-2 agonist. And so alpha-2 functions are generally unconscious, like things that keep you alive, breathing, swallowing, awake, sleep cycle functions, heart rate. It doesn't take much to get toxic effects of clonidine. Again, these kids are going to look like they're going to be in, comatose state, confused. They're going to have a low heart rate. They're not going to be breathing very well. They're hardly going to be breathing at all. And so they're going to look a lot like an opiate ingestion. The only difference here is generally time to onset is a little bit further out than it would be for one of the other prescribed or street level opiates. There's a biphasic pattern of presentation. This is probably not as helpful clinically because no one's going to call you when their kid's hypertensive, and no one's even going to know that either, unless for some reason you're checking your kid's blood pressure at home, which would be weird. They're going to call you when the kid starts getting bradycardic, has slow breathing, and becomes unresponsive. And so when you show up, they're going to have pinpoint pupils, and you're going to appropriately give them Narcan. And again, no specific antidote, but there is a graded response to Narcan in a clonidine overdose you're going to have to give massive amounts, large amounts. And a lot of times, if these kids come in, they end up going to the ICU on Narcan drips or naloxone drips. So again, you may not even know it unless someone hands you the bottle and is like, here's what they took. Just treat it like an opiate overdose and you're safe. You're doing everything that you can. All right, last of our toxidromes, beta blocker overdose. This one is actually strangely pretty common, but infrequently is it severely toxic. So this is, once again, a kid looks unwell. They're going to have low blood pressure. They're going to be bradycardic. They should not have small pupils, unlike the other two that we've talked about. And then they are going to potentially have low blood sugars. Again, one of those intervenable H's. It can progress to the point of bronchospasm. They can get so bradycardic that their outflow drops off, and they're essentially in this medication-induced cardiogenic shock state. So this is kind of similar to the infants who have a really slow heart rate. They're the threshold to intervene and provide chest compressions on these people. Again, it's going to be a heart rate less than 60 if they look like they're perfusing poorly. A couple different options for treatment. Atropine, obviously, we all know that for bradycardia. It's not super specific here, but should work. Glucagon, again, I'm not sure how often that's actually given in a pre-hospital setting. We talked about it yesterday being pretty darn expensive and not really stocked much. The one point here to make, though, is if you were to ever find yourself in the unique scenario where you've got a patient, not even a pediatric patient, but an adult with a beta blocker overdose, their mental status is already going to be less than stellar, and glucagon will almost certainly induce some vomiting or nausea. And so you just be prepared that if you're giving glucagon, have your suction hooked up and be prepared for an airway issue potentially developing, because it's a very potent emetic agent for whatever reason. You can also give calcium for stabilization of the cardiac membrane. And then, of course, you can always start pressors or inotropic agents, dopamine drip or epi, norepi on these patients en route if they're really collapsing. All right, briefly, we'll talk about post-arrest care. Again, this is something that, based on a quick literature review, has kind of like swung all over the place in the last 10 or 12 years. So maybe 10 years ago, they wanted everything to be up, meaning like they wanted fevers to be high. You could allow some hypertension. You could allow some hypercapnia. And then about 5-6 years ago, they said, no, actually, it's probably better if we bring everything lower than normal. And then in a strange twist of fate, in the last couple of years, they now said just make everything normal, which makes it easy on us. So normal temperature, avoid hypotension, normal CO2 managed on capnography. A couple other points to make here is what you're doing in post-arrest care is you're preventing essentially four main things. This post-arrest syndrome, and this can develop days to weeks after insult. Brain injury, obviously, if they've had any downtime, you're worried about hypoxic injury. Myocardial dysfunction or a poor recovered EF after someone's had a heart attack and had their chest crushed. There can be this systemic ischemic response. In other words, was I down long enough that my fingers and toes didn't get good perfusion, and now I've got chronic effects. And then again, people who have just arrested are much higher risk to re-arrest in the following days or weeks, and so you want to prevent that. So by normalizing all these values and doing nothing that you would probably do, even if they didn't tell you to do this, you are preventing a lot of these complications. One point here, again, not so much for pre-hospital, is comatose and encephalopathic patients post-ROSC should be on long-term EEG to make sure they're not continuing to seize from a hypoxic state. And then again, more really discouraging data on this Wednesday morning. 60% of patients who make it to the 6-hour mark will survive to discharge. The other 35% will not. And then even those that do go home, again, usually not the same functionally, not the same neurologically. Again, this is the this just runs back through the H's and T's. We've kind of already hit all that. Put this in here. This is from y'all's EMS protocol. A lot of this we have talked about. The only point that I wanted to make here that I'm not sure that we've harped on enough, and I wanted to highlight for Dr. Ferguson as well, is y'all's guidelines here. They say discouraged endotracheal intubation in the pediatric patients. In other words, place an iGel and bag them, and that's all you have to do. Again, so to boil it down really simple, full-on arrest, you have no other information. You're going to provide continuous chest compressions. You're going to provide breaths for every 2 to 3 minutes through an iGel or a trumpet or an LMA or something similar. and transport. If you can give adjunct medicines like we described en route, Narcan, sugar, or identify any other reversible H's and T's to tell us about or begin addressing, then that is exceptional pre-hospital care. There's nothing else you can be asked to do. Here is y'all's flow chart as well. Lots of flow charts through this, I'm sorry. We've already covered everything on here. The only thing that I'll mention is that y'all do allow for higher joules per kilogram on subsequent defibrillations. I don't really see the downside. You're shocking someone who, if you don't shock, is certainly going to die, and if you do shock, they might not. So agreed. If indicated, sodium bicarb, again, I had that on a slide as well. Didn't spend too much time going into that. I don't necessarily think that's super pertinent for today's talk, more so an ICU type thing. Ferg, how do you want to run these questions? You want to? Gotcha. All right. Well, I will stop there then. The rest of it's just questions.
Great job, sir. A couple of good points he made. One thing I will stress is that when you think about managing pediatric cardiac arrest, everybody talks about kids are not small adults. I get it. But the skills that you use with your adults are the same skills you use for your kids. Recognizing sick or not sick, managing the airway. So I think, one of the key things he talked about, you recognize there's a kid that's unresponsive, altered, doesn't have signs of perfusion. You could be on the chest doing chest compressions just like an adult. Okay, someone else should be doing passive O2 or managing that airway, all right? And then quick early IV access, and we're giving our drugs. And what's the first drug we're giving cardiac arrest for adults? Anybody know? Anybody care? Epinephrine. So what's the first drug we're giving kids? Epinephrine. Yeah, so same thing. So, he talked about the outcomes for kids long-term are bad, just like adults. What we're trying to prevent here is anoxic brain injury. And the way you prevent it is early chest compressions, aggressive oxygenation, passive O2 on these folks, and then early time to epi. So the state's kind of limiting what we give in adults for epinephrine for cardiac arrest. And my suggestion was first dose in cardiac arrest is pretty quick. Second dose of epi in the adult is at 5 minutes. Third is at 5 or 10 minutes. And then you make a decision, do you need more? And what are you going to do with that? For kids, I think it's a little bit different because kids arrest for different reasons. So I would say early hands-on chest compressions, passive O2, opening the airway. Yeah, we're going to look for shockable rhythms, but we're going to get that first dose epi in because if they're in VFib or VTAC or they're in PEA or asystole, what drug do we give them in cardiac arrest? It's still epi, right? So the medic or the advanced is drilling them, putting the line in, and giving that first dose of epi. Who here knows what the dose of epi is in cardiac arrest in kids? Yeah, so great. Yeah, so that's one drug I recommend you memorize. I memorize it too. I memorize the volume because I can't say 0.01 mg per kilo and then translate that into a volume because my eyes start crossing. So I remember it's 0.1 cc per kilo in pediatric cardiac arrest, okay? If you're on the chest, you're doing the O2, somebody's throwing the monitor on, by the time you get a line and draw up your epi, it's time to look at that rhythm. And you can say, okay, now I'm looking at the rhythm. Is it shockable? Is it not shockable? Do we rescue them with our aggressive airway and chest compressions? If not, we don't need the epi. And if not, by then you can push that first dose epi. So first dose epi is pretty important in these kids. The other thing he mentioned was volume. Resting normal blood volume for an adult is about 70 cc's per kilo. Kids, it's 90. That doesn't mean they got an extra 20 just to hang out with. They can waste it. That means they need that volume to get their cardiac output. So when you're giving that epi, you're also giving a fluid bolus on these kids. Saline or LR, either one is reasonable, and it's 20 cc's per kilo, okay? And sometimes that means you're hanging the fluid, somebody's squeezing it in, and then after you give the epi and you sit back, then you're calculating that dose to make sure you're not giving too much. Because if you give 20 cc's per kilo and it doesn't work, what do you give them? 20 more cc's per kilo, right? So don't hang a liter bag on a 2 kilo kid, but be aggressive with this because we're trying to get their perfusion back up. So great stuff. Bicarb, I know y'all probably heard me talk about bicarb in adults. If you're giving bicarb, you should have already given calcium because if they're acidotic enough to get bicarb, they're probably hyperkalemic. In kids, you don't see that much hyperkalemia in reality, and plus, if you're drawing up bicarb, it's going to take you a few minutes. I'm not saying you don't give it, but it's probably a little bit further down the road. The Narcan, no risk. The only risk to giving a kid Narcan in cardiac arrest is the same risk in adults, is that it takes away your time that you're drawing up your epi. So if you got extra hands, or if you've already got the good airway management, you got your fluids, first dose epi, you want to give that Narcan, yeah, roll tide, give the Narcan, okay? The clonidine is a great one. So I've seen a lot of clonidine, and Narcan actually works pretty good for that. Like you said, the doses are higher, but still, if they're symptomatic and in cardiac arrest, you can do the same things we've already talked about, and you can get to that Narcan at that point. Do y'all carry glucagon here? Yeah, so nobody's carrying glucagon for the most part. It's expensive. Potentially, you'd have enough glucagon to rescue a kid from a beta blocker overdose if it's a small kid. If it's an adult, there's really nobody carries enough glucagon to salvage them. It's expensive, and sometimes in the ER when we've done it, we're going to all the crash carts and pulling all the glucagon out just because it's hard to get it. So, but he did mention other things you can do, such as epi doses, right? If you're carrying norepi, you can do norepi. And then calcium. We've talked a lot about calcium being a dirty presser. So calcium's a great drug. Just make sure you give the right dose for that. What else can we talk about? Airway management. Remember, less than 3. Technically, you have to call med control to manage the airway with an ET tube. Are y'all using iGels here? What do y'all use? iGels? Yeah. Yeah. They pulled
Do you have the pediatric sizes for the iGels?
Yeah, perfect. Yeah, so I think the states changed it. You have to have 2 sizes of iGels. My suggestion would be that if you have to have 2 sizes, I would have 2 adult sizes, the biggest one, and then probably a 3, and then get all the peds, because it's so much easier to manage the airway with the iGels in kids. They took the Kings off the market, so if you're carrying those, I would probably not have those on your trucks anymore. There's some air cues out there. You can also just use nasal cannula, OPA, and a BVM. That works pretty good. Remember, when you're getting a kid up and you're trying to get their airway managed, he mentioned they have bigger heads, so you want something under their shoulders. The way I think about it is I'm going to lay over and I'm going to look at the kid from the side, and I'm going to see, is their ear hole in line with their shoulder? And if it is, you got the right angle there for that. What else did I have? LVADs, yeah, those are scary in kids. Those are scary and for adults as well. I would say that if they're altered, unresponsive, the glucose is okay, you're probably going to intubate them or put an iGel in them. Then you can use your CAPNO to determine if they're having perfusion. If the CAPNO is low, they're probably dead-ish. They get chest compressions. If not, I would recommend call med control to get a doctor's name on that chart to back you up for whatever you do, right? Atropine. Dose of atropine is 0.02 mg per kilo, but there's a minimum dose, which is 0.1 milligrams. You give less than 0.1, you get a rebound bradycardia. Just like for the flight guys that are using NEO, you'll see that sometimes, so be careful with that. And then the last thing I'm going to ramble is, you talked about the transition. We're not doing the 2 fingers. There was a study in 73 that came out that talked about that was causing fatality, and it was put out by Lee and Norris. So it was the 2 fingers. You shouldn't use that, right? 2-finger death punch, Bruce Lee, Chuck Norris. Nobody got that. I thought that was funny, but never mind.
I got it.
Okay.
I just didn't laugh.
Okay. Thanks a lot. Okay. All right. Fair enough. Well, he's the only one around for the 73 documentation anyway, but that's okay.
Okay, here we go.
All right. Other questions or comments, Dr. Sullivan, or folks online, or Chief?
Well, I appreciate the lecture on the pediatric cardiac arrest. I think you did a great job covering everything. I think the main point here, though, is that, we've been really encouraging people to use pit crew CPR to stay on the scene to resuscitate adult patients. And we've seen improvement in cardiac arrest resuscitation rates. There's a couple of big studies that have been published for a few years now showing that on the scene time for adult cardiac arrest, the longer scene times are associated with better outcomes.
Yeah.
But pediatrics doesn't get research because we don't research on kids.
Right.
So the pediatric side is actually way behind the adult side when it comes on what's the best thing to do for resuscitation. The other issue is that many agencies, if not most agencies in the central Alabama area, now have Lucas devices for adults, and that's not going to apply to pediatrics. And in my experience, I hope it's different now, but when a kid's really sick or in cardiac arrest, I think the EMS traditional response to that is to run out to the curb and either meet the transport unit or put the kid in the transport unit and run as fast as we can to the hospital, and not really do many effective interventions because we're too concentrated concentrating on transport too much. It's difficult culturally to stay on the scene with a pediatric patient, but I think if we're going to improve resuscitation rates, we have to do that. That's an opinion, but I'll tell you a fact. I hope you're practicing adult cardiac arrest with your crews and the people you're going to run the calls with pre-assigned positions. And I would say it's just as important, if not more important, to practice on pediatric because it's going to look different. It's going to be different. There's not going to be a Lucas. There's going to be drug dose calculations you need to get familiar with doing. Hey, we need to all agree where we're going to keep the Broslow tape or whatever we're doing to help us with drug dose calculations.
Yeah.
Right?
Yeah, I agree.
All those things are critical. If you've done EMS for more than 10 seconds and you've been on a pediatric call, it's usually a hot mess. I don't know if that Murphy guy is involved, but every time I've ever needed a Broslow tape, it's never been where the Broslow tape is supposed to be. Every shift, has a different idea where you're supposed to put it. So that needs to be standardized, and those are types of policies that are really important because they can have an impact on the patient's life.
Yeah. Are y'all using Handtabby or Braslow? What are y'all using out here? Braslow, yeah. So I know some places have the Handtabby app. That's fine. The Braslow's fine. But like Chief said, the key thing is you got to know how to use it. If you pulled it out 2 years ago, last time you looked at it, you're not going to run a good pediatric code. And like Chief said, just like on adults, with kids, work them where you find them. Okay, and that's the scene's unsafe. Manage the airway, because even if you're lucky enough to be 10 minutes from a hospital, if they're hypoxic and hypotensive for 10 minutes, the brain does not live, right? And so that's the goal, is to save the whole body, but also the brain. So you don't want this apneic, you don't want the anoxic brain injury. So you got to manage the primary exam stuff, airway management, good chest compressions, early epi use, those things. And then you can make a decision if you're going to move or not. But the Lucas, I used to argue that if you didn't have a Lucas with adults, there's no reason to transport, because I'd bet you my $7 I got left this month that chest compressions in the back of a rescue going to a hospital are horrific, no matter what you tell me. If you don't have a Lucas on kids, it's going to be tough. Plus, your safety is at risk there, too. So work them where you find them, give them the best chance of survival. We have some great resources in this state. So the Children's Hospital has a coaches program where they'll come out to your institution or your agency and do some ped sim, good stuff. They can't hit everywhere every year, but they're available. Good resource. And I know that from the state level, I'm going to bring out During's name, and he can call me names. That's fine. But I've heard him say as well, his goal is work them where you find them, give them the best chance of survival, and then make your transport decision. But you got to do it right the first couple of minutes or people do die. So
yeah, they're not going to have a good outcome. They never have had a good outcome in pediatric cardiac arrest when we treated them like the kid was a football and we pitch around the end,
right.
Jump in the transport unit and drive like Starsky and Hutch to the hospital.
Yeah.
Yeah, I feel like I say that every time we mention a pediatric patient in EMS Challenge, is like having your resources available and knowing where they are and how to use them and how to get to the answer quickly. All these drug calculations, shocking joules, all those things are math problems, right? A lot of times, and the numbers aren't always the same. So we all know that these situations, fortunately, are few and far between. They're less common than when dealing with adults. So you don't get as many reps as this in real life. So having your resources handy to help you through these situations that are obviously more stressful. Obviously, you need to kind of cognitively offload. I use that term a lot when talking about pediatrics. You want to take as much of that like brain power out of making calculations and coming up with the right dosages and things like that, and focus more of that energy on the life-saving interventions and running the code efficiently. So having those resources available and knowing where they're at is, I think, super important. I want to make a plug for those pediatric coaches deal. We had a simulation yesterday with the pediatrics faculty at Children's, and it was fantastic. They put the stuff on for free lunch, all that good stuff. And most importantly, it's excellent training with a lot of good resources available there with pediatric ICU and emergency trained physicians, as well as EMS ones as well. So that's an excellent resource that I would try to take advantage of. And frankly, I learned as much as anybody at the simulation yesterday. So I'd make a plug for that as well.
Yeah. Not a lot of reps in peds, so that's why the more reps you get in training is better. And why not train with the folks that do it every day at children? So it's a great resource. I got a text. One of the resources out there is also PediStat. I don't sell any of these things, but I would say whatever resource you use, know how to use it. So I guess.
Yep. Know how to use it and make sure that what you got is up to date. So check your transport unit. If your Broslow tape was published in 1977, throw it away. Spend the $30 on a new one or $50. They're all overpriced. Everything to do with pediatrics is overpriced. Bite your lip, spend the money if that's what you're going to use. But per agency, I think it's important that we all use the same resource.
Yeah.
Okay. A lot of people use online apps. That's great. Make sure you don't have big areas of your coverage where you can't get a signal if the app requires Wi-Fi. Make sure your phones are always charged if that's what you're going to rely on. And Dr. Ferguson probably hates for me to say this, but hey, if you're a paramedic, you should know how to do the drug dose calculations. If you don't know how to do them, I'll be happy to teach you. But the key to it is to practice regularly. And if you know how to do them manually, then when all that other stuff fails, you can still give good care to your patient. And in my experience, all that other stuff fails quite commonly. So, great lecture. Thank you, Dr. Washington. We're going to take about a 5 or 10 minute break. Let everybody stretch your legs, and we'll be back with Dr. Sullivan. Everybody, welcome back. We've got Dr. Sullivan's going to talk to us a little bit about blood transfusions. Take it away, Doc.
Yeah, this is a fun topic, and I apologize. I sound like I chain smoked like 50 cigarettes on my way up here. Getting over a little bit of a virus that ran through the house. So forgive my raspy voice, but we'll talk about pre-hospital blood administration. I think this is a fun topic. I think there's a lot of cool history to do with this and a lot of emerging evidence. It's a topic that makes sense, like it makes common sense for someone who doesn't necessarily have anything to do with medicine. If you lose some blood, giving some blood back typically helps. So it's a fun concept for me because I don't have to jump through a lot of hoops to understand it. But there is some cool science and stuff like that behind it that we'll kind of talk through. We have to disclose that we don't have any financial relationships per UAB policy, and I do not. I wish I did. That's why this matters. So in trauma in particular, hemorrhage is the leading cause of death in the pre-hospital setting. So just pure loss of blood. Whether that is, something we can intervene on with tourniquets, with wound packing and things like that. The bottom line is that we're losing blood, right? So we need to find a way to get blood back into the system faster. And so implementing hospital or pre-hospital blood administration is a way that we're looking at doing that. A lot of these deaths from, obviously, in the pre-hospital setting are from the acute blood loss, right? So how do we get that blood to them faster? How do we improve their hemodynamic status pre-hospital without interrupting their coagulation cascade when we give them crystalloid and things like that? Obviously, blood out needs blood back in. So the goal is simple. So we want to understand why blood changes outcomes when we give it in the pre-hospital setting as opposed to waiting to the hospital. So like I said, the concept's pretty simple, right? So think of our bodies as these meat vehicles and bags of blood, right? So you poke a bunch of holes in the bag of blood and blood pours out. Your tank gets empty. You can't live without gas in the tank. So we've got to find a way to get that back in, right? We stop the blood from leaking out and we put blood back in. Makes sense, right? Pretty simple concept. So hemorrhagic shock physiology. So when this starts to happen, right? So it's not just the loss of blood. It is the other things that are occurring because of the loss of blood, right? So when we lose a significant portion of our kind of total blood volume, a couple things start to happen. We start to get cold. We start to get acidotic because we poorly perfuse the rest of our body. We start to produce a bunch of lactic acid, drop our pH, and further affect our coagulation cascade. You get a lot of endothelial dysfunction because of that. And so you start to leak other fluids and proteins and things like that out of the blood. And so you get in this kind of death cycle, right? We call it the trauma triad of death. We start by losing a bunch of blood, right? You start to become acidotic. We use up all of our clotting factors. So we develop what's called coagulopathy. As we start to lose that blood, we lose our body temperature, which further worsens the coagulation cascade. It affects our clotting factors, makes us more acidotic, and we get in the cycle, right? So once we get into the cycle, this is a problem. This is a complex slide. This is the coagulation cascade in its entirety. Is it important for you guys as pre-hospital providers to understand all of this? Maybe, but the most important thing is that you understand that there are a lot of components to the total coagulation cascade, that your body takes a normal blood that's flowing around your body and turns it into a clot to help prevent blood from leaking out. So there's two pathways, right? So there's the intrinsic system, there's the extrinsic system, and they all come together in the common pathway. We have medicines, obviously, that we give to people to stop this process from happening. So people who have AFib, people who have conditions that make them clot easier, we give them blood thinners to prevent this cascade from going off, causing a clot that causes a stroke or whatever, DVTs and things like that. So we affect this system in a way that's therapeutic sometimes. There's pathologic processes that have to do with this. So you have like your have sickle cell disease, you have hemophiliacs and things of that nature that all have problems with various aspects in this cascade. But the most important thing for you to understand is that there's a lot of factors here, right? There's a lot of things that go into making a clot and to keeping that clot strong and in place. And this is all affected by that kind of pathway, right? The acidosis and the using up of these factors. So why is this stuff important? This is supported widely by various organizations across kind of the medical spectrum, right? Whole blood is good, says the National Association of EMS Physicians. Their joint statement recommends pre-hospital blood as the first-line treatment over crystalloid. The American College of Surgeons Committee on Trauma also advocates for widespread adoption when this is feasible for pre-hospital transfusion, as does the Joint Trauma System and Defense Committee on Trauma. They recommend that transfusion begin within the first 30 minutes. The Pre-Hospital Trauma Compendium is a great online resource for you for pretty much anything that you want to know about pre-hospital trauma. They've got typically a good statement of recommendations or policies on that. But in line with the NAMSP stuff, they recommend the use of blood components over crystalloid as a first-line treatment in the pre-hospital setting for acute blood loss and hemorrhagic shock. So brief history. There's a lot of cool history that goes into this, and I'd recommend you kind of take a look into it. We won't go into super crazy detail with this, but we were all over this, giving whole blood near the battlefield in World War I. And this is back in the time when we were giving people like ether and stuff to, do field amputations and things like that. We still were on top of it, right? This is, like I said, it's not necessarily like a super complex topic. It makes sense to try to give blood back to a person who has lost it. So even back in World War I, we were doing direct donor to patient transfusions. We had issues with storage capacity and transportation and infrastructure and things like that, but we knew that there was something to this, right? That this was what we needed done. In the Vietnam era, we started really pushing hospitals and pushing care closer to the front lines. This is when large volume transfusion kind of came on the scene. This is also when a lot of the transfusion reactions, things like trauma resuscitation ARDS, or what was called at that time Da Nang lung, which I think is one of the cooler names for a pathology out there. But we started to kind of shift back towards this large volume resuscitation as fast as possible for our soldiers who were injured in hemorrhagic shock. In the 80s to 2000s, you start to see civilian EMS shift back towards crystalloids and things, right? So traumatic injury, hemorrhagic shock, we were given crystalloids. We're loading and going and trying to get to a trauma center and to a surgeon before we do any of these damage control interventions. At that point, the thought was more of a volume resuscitation than anything. Once we got back into kind of long-standing conflict in the Iraq and Afghanistan wars, this is when you start to see more centralization and going back more towards these pre-hospital transfusion deals. So we developed the TCCC, the Tactical Combat Casualty Care. We start to return back to whole blood and doing this as quickly as possible and as much damage control outside of the hospital before we got to a more formal medical setting. That's when these things started to come back around. And now in modern civilian EMS, now there's this big push to get whole blood or component therapy or whatever, but a preference on whole blood back out into the community and to the point of care and start that kind of damage control resuscitation on scene or as early as possible. So we've seen the shift, right? We were thinking whole blood back in the day. We moved more towards like a crystalloid type volume resuscitation, and now we're back to whole blood on scene. So it's a cool kind of walk through history if you really dig deep into it. A couple of cool photographs. This was kind of a original blood transfusion type setup, like glass canisters, a lot of what appears to be like prehistoric or barbaric type instrumentations and things, the way they kind of carried this stuff around. Super interesting. It was back in World War I. They're treating a guy, as you can see, with some volume resuscitation there. He's got a glass kind of container in his hand there with some tubing going to the patient. And then you got your kind of early phase blood transfusion units or ambulances that are transporting patients. So just kind of some cool photos there. So from the military, this is where a lot of our early data is coming around, right? Once we got back into the Middle East in the 90s, 2000s, this is when the combat casualty care started to come around. This is when we started really synthesizing data that showed that earlier blood is starting to improve outcomes, that patients are doing better when they get blood products in the pre-hospital setting. They started to recognize that whole blood, as opposed to component therapy, seemed to be the more logistically simple way of doing these things. Whole blood has all of your components, right? It has your PRBCs for oxygen carrying capacity, and it also has your plasma and things that are rich in your actual clotting factors. So you're getting everything in one bag of fluids along with volume control or volume resuscitation. And that's when we started recognizing too that the earlier that we were able to transfuse people, that people were doing better. So essentially, TCCC, their key impact was they started to shift that trauma care back out from the hospital and to the point of injury, emphasizing kind of a field-based intervention. So what is the actual evidence here? So these are some really good studies that I would recommend you look into that kind of show the military's data that this was working, right? So this first study, Spinella et al. In 2009, kind of showed that there was a significant improved 24-hour and 30-day mortality benefit versus component therapy when we're talking whole blood. Shackelford et al. That was published in JAMA in 2017. Pre-hospital combat blood during medevac improved acute and 30-day outcomes. So giving bloods while we're transporting from scene to the more definitive care was improving outcomes both acutely and a month later. Spinella in 2008, the 6,000 units of battlefield whole blood showed improved early and 30-day survival compared to component. Fisher et al. In 22, military resuscitation with whole blood and blood products is standard and survival associated with pre-hospital combat care. And then the bleeding edge registry going all the way through 22, blood transfusion with kind of volume and component shows reduced early mortality in all battlefield cohorts. So a wealth of evidence from the military that, that kind of paved the way for this to start making its way back into the scene for civilian EMS. And right now there's a lot of cool data, if you look into it, that's coming out of kind of the Ukraine-Russia conflict. Particularly, there's been a few summits. There's groups like the Global Surgical Medical Support Group that have done a lot of oversight and synthesis of data on how they're taking care of patients that are wounded in these wars. This is a particularly interesting one too, in how things are kind of developing in the modern conflict landscape, whereas in the War on Terror, we had a lot of air superiority, so there were quicker transports from scene of injury to more definitive care. But in the Ukraine war, there's less air superiority for the good guys. And so there's longer patient transports. There's longer time of first contact where medics are running resuscitations for longer periods before they get to damage control surgery or get to more definitive care. So there's a lot of cool data that's coming out of there. A couple of headlines I included on here. There was a Ukraine's first blood transfusion in a trench. And then just kind of a general article about Ukraine starting to train all of their combat medics on pre-hospital transfusion. So a lot of interesting things that are coming from that conflict. Now, how does that bridge into the civilian side? So some really cool studies out there. First, the Gaiety et al. In the Journal of Trauma and Acute Care Surgery in 25. So it was a comprehensive review of pretty much all of our civilian literature. And the take-home message was essentially that the low titer O negative whole blood appears safe, it appears feasible, and it's likely beneficial. Some of these are caveated. They don't show like full-fledged, or sometimes they don't show a full like mortality benefit. But a lot of times that's because there are shorter transport times, where there's transport times of 5, 10, 15 minutes. There's not enough time to really show this demonstrable effect, right? And perhaps some of the effect is coming from, just getting the patient to more definitive care in a shorter amount of time. But I think there are plenty of studies out there that are showing that, in particular, when we have longer transport times of 20, 30, 45 minutes, that whole blood in the community or in civilian EMS is showing great benefit. But these are all very excellent studies that essentially are showing at least feasibility and most likely a benefit for patients and survivability. So the trials and takeaways that you can kind of take from the civilian EMS stuff is, these are kind of the biggest ones that have come out so far. So proper is component. So they're doing 1-to-1-to-1 therapy. When you consider what 1-to-1-to-1 therapy is, that is essentially whole blood, right? So it's PRBCs, plasma, and platelets, all components of whole blood. The PAMPER trial showed improvement with plasma in the air. Now, plasma is interesting just because it's volume resuscitation, it's all your clotting factors. If, this is a case where necessarily the oxygen carrying capacity wasn't necessarily the thing that is most important, then sure, like plasma works. The combat trials showed really no difference, but again, the caveat of like shorter transport times. So it's not showing you're not getting enough time really for your benefits there. But all in all, whole blood civilian programs are starting to show great benefit and are becoming the standard of care when it's feasible. So as I said, just to kind of drive home the fact that, we're talking like component therapy and things like that, whole blood is all of these things, right? So it makes the most sense kind of logistically when you're carrying these things around. It contains your clotting factors, volume resuscitation, and oxygen carrying capacity. So that's kind of why we're trending up to whole blood. So indications. So per our state guidelines, when are we giving this blood? So essentially this is for the patient that's showing evidence of hemorrhagic shock in the setting of a known traumatic injury, in a known traumatic injury mechanism. So this is someone who's tachycardic, hypotensive, has obvious signs of massive bleeding, or from a medical standpoint, somebody that's showing obvious signs of massive GI bleeding, whether that's a cirrhotic patient who is vomiting blood like Mount Vesuvius, or a little old lady who's on Eliquis and has a constant flow of maroon-colored stool from her behind. These are patients who are showing obvious signs of GI bleeding. The other indication is in our pregnant population. So patients that are having significant vaginal bleeding, whether they've had like a placental abruption, they've had an ectopic pregnancy rupture, things of that nature can cause massive bleeding in those patients. And these are young, healthy patients that certainly need our intervention. So contraindications per the Alabama EMS protocols, these are patients who have known personal or religious objections, or patients, it says less than 3 years of age, but Due to a lack of evidence, our Alabama state protocols say less than age 15. It is not recommended. And then above 15, we treat it kind of like an adult. In reality, if you give someone TXA, if you give a kid an hemorrhagic shock, TXA, I don't think anybody's going to say a word to you when you show up at Children's. So I don't think that's a big problem. But for our protocols, it is contraindicated. So kind of our procedure as we walk through this, which this is all kind of protocol driven, but this is also like a training thing. This is something you just get used to doing, right? So I can walk through this whole thing, but essentially we get our access as large bore as possible, 16, 18 gauge. But all the time, not all the time, that's not necessarily the case. Sometimes we're doing IOs, sometimes we're getting what we can get, right? Preferably you want to shoot for 2 points of access. You want to have a backup to your backup as often as you can. So making sure we got good access, large bore, and having a secondary line. So we confirm, we're keeping our blood, at a temperature appropriate setting. We're agitating the bag. We're using filtered lines only. We're using a blood warmer to get into the patient to help combat hypothermia. Whole blood is preferred. For an adult, we just give it basically by unit, right? So if you've got an adult patient who's shot in a hemorrhagic shock, we're just getting a unit of blood in them as quick as we can. For pediatrics, a little bit different. You get a gross estimation of their body weight in kilograms. This is where like a Broslow tape or a PD-Stat app comes in handy. It can give you a gross estimation of how much that patient weighs for you to give an appropriate amount of therapy. So as far as component therapy goes, we typically are giving a unit of PRBCs up front, followed by a unit of plasma. But a lot of times maybe you're just carrying PRBCs. But we typically go with a 1-to-1-to-1 ratio there. Same setup for the pediatrics in that standpoint. We're still using that same weight-based dosing. So we kind of monitor from that standpoint. We particularly look for hemodynamic improvement, hopefully, as we restore volume, improve perfusion. Typically, we see improved GCS scores. We see improved heart rate and blood pressure and all that good stuff. But we watch for signs of transfusion reactions that sometimes do arise. We reassess, particularly in pediatrics, after we've given that weight-based dosing to make sure that we don't need to give more. And afterwards, we're giving the remaining blood to the facility per the protocols. So with that, we'll kind of walk through a few cases and just give a few relevant examples. Talk through a few adjuncts as well, but we'll talk through the cases and kind of indications when it's obvious that we give blood to these patients. The first few cases, the traumatic injuries, are real cases. So we get the benefit of actually seeing our work in real life on paper. So this was a patient, approximately 22 years old, that was found supine after a single gunshot wound to the left chest. When you arrive, there's minimal external bleeding seen, but the patient looks like crap. So his GCS is 12. He's confused, not making a lot of sense. Heart rate is 150. His blood pressure is 70 systolic. His respiratory rate is 32 and labored. He's in obvious distress. You get a pulse ox on him and you see briefly that he was 89%. He's very pale. He's cool to the touch. He's diaphoretic. He looks like he is about to die because he is. So you do a primary survey. You note that he's got markedly decreased breath sounds on the left side. But like I said, there's no obvious external hemorrhage. So the patient's tachycardic hypotensive shows signs of maybe obstructive, maybe hemorrhagic shock. Who knows? So you do your assessment. You find the single penetrating injury there to like the left axilla, left chest, however you want to describe that. So what are you going to do? So we're going to do a number of things. We're going to kind of talk through TXA to begin with in this patient. So what are some initial things that you guys would do in this situation? You got a guy that's shot like this and with the vitals that I described. Yeah. 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 So things like chest seals, chest decompressions, things of that nature are great initial interventions as well as establishing IV access or IO access, however you got to get it. Good. So another thing we're going to do down the line is give some TXA, right? So just to kind of run through TXA, this is an agent that helps essentially stabilize clots, right? So once you get deep off into the kind of lethal triad, as we discussed, you start to break down your clots too. You start to lose their integrity, they break off, and therefore more bleeding occurs. So we give TXA to help kind of prevent clot breakdown, right? So it decreases plasmin activation, which results in essentially inhibition of the fibrin clot degradation, which stabilizes your clot. We could thumb back to the whole coagulation cascade, but essentially this is a snapshot on the bottom right there of how it kind of helps stabilize your clotting, stabilize your blood clots from that standpoint. So our indications for that, as stated, greater than 15 years old, signs and symptoms of severe hemorrhage, whether that's traumatic or medical, hemodynamic instability, so obvious signs from your vital signs standpoint, altered mental status or signs of poor perfusion, duration from initial injury less than 180 minutes, and evidence of kind of that peripheral vasoconstriction or hypoperfusion. Contraindications, greater than 180 minutes, less than 15 years old, patients who have contraindications to that, which there are a few. So field actions, as we said, you decompress the chest, the blood pressure remains low. So it's likely a massive intrathoracic hemorrhage, right? So he's lost a lot of blood, not obviously externally, but he's lost a lot of blood, right? So we give our whole blood. This is going to restore our preload. So he's got a lot of pressure inside of his chest, presumably from this blood and from the air that you hopefully decompressed. So we're going to help him. We're going to give him volume. It's going to increase his preload and help him pump against that and push through that pressure. It's going to increase our coronary perfusion. It's going to improve our cerebral perfusion, hopefully improve our perfusion across the board. But it also buys us time. It improves our hemodynamics and gives him some more clotting factors back, gives him more oxygenation, more ability to make clots and get to the operating room to manage this injury. So you give him a unit of whole blood, and his vital signs improved to 100/80. Heart rate comes down to 110. His SpO2 is up now that you've decompressed the chest, and his GCS is 14. When he gets to the X-ray, gets to the ED, this is his X-ray. Seems a little bright on the screen, but essentially what you see is a lot of white on the left side of the chest, right? So he needs a chest tube. He's got a massive hemopneumothorax. And if you can see kind of the cardiac silhouette in the right chest, it's shifted over a little bit more into the right chest than you would expect, which is indicative of some tension physiology. So he gets a chest tube, as you can see there. He's a little bit rotated in this picture, in my opinion, but because it still looks like he's got a bit of shift into the right chest, but that pressure is now relieved on that side. He's still got a lot of blood and pulmonary contusion and things like that in the left chest, so he's still pretty hazy, but you can see some aeration in there now. He's intubated now. And you can also see, just as kind of an aside, you see these black strips kind of along the mediastinum in the right chest. He's got evidence of like an esophageal or a tracheobronchial injury that's caused him to develop a pneumomediastinum as well. So this guy was in bad shape. But fortunately, this guy did survive his hospital course, albeit very complicated and very long. But in my opinion, based on our initial vital signs, we most likely bought this guy a chance in the operating room. And therefore he got his surgical intervention and survived. So I think that's a save or saved by EMS and by timely blood administration. So our second case is pretty similar. This is a gunshot wound to the abdomen. This one's a pretty profound turnaround in the pre-hospital setting as well. So he's 24. He's found seated against the wall with a single gunshot wound to the right lower abdomen. There's minimal external bleeding, again, kind of as your first case. So your initial assessment is this patient has a GCS of 11. He's confused. He's lethargic. heart rate of 148, systolic blood pressure of 72, respiratory rate of 28, and his SpO2 is 96%. He also is showing signs of hypoperfusion with pale skin. He's cool. He's diaphoretic. He's got a distended abdomen. It's very tender. He moans and pushes you away if you press on his belly. But again, no massive external hemorrhage is identified. So he's profoundly hypotensive. He's profoundly altered. So this is consistent with hemorrhagic shock from an internal or intra-abdominal injury. So we're starting to get ultrasound into the pre-hospital setting, right? I think there's a few ways that ultrasound is helpful in these situations. One, it can help you identify things like this, like a grossly positive fast exam, and lets us know that this patient probably needs to bypass most interventions and go to the operating room, especially if this is an isolated abdominal injury. Also, I think it helps, when you're evaluating your lung fields. I think it can help you with vascular access, things of that nature. So this is the way. This is one of the innovative ways that we're headed with pre-hospital care. So what you see here, this thing that looks like a shark fin or something that's flopping in the wind there, that is the liver tip, and the little circular thing down in the middle of the screen is the kidney. Now all that black there is not supposed to be there. This is not as profound an image, but has the arrows to kind of help you delineate. So you see liver, kidney, and all that black stuff is blood. In a normal ultrasound, those lines are nice and flat. There's no separation between the two other than like a line of fascia that kind of lights up, but certainly nothing black there that separates the two layers. Your other views that you might find in the top left, this is a suprapubic view, or a view of the bladder. So the bladder obviously has fluid in it, and it appears black as well. But you see down below the bladder, there's two spots that have some similarly shaded areas that are consistent with free fluid in the pelvis as well. Bottom left, you have a view of the left upper quadrant. That is the spleen and a kidney. That's a pretty grossly normal one on the bottom left, but on the bottom right, you see where the spleen is kind of separated from the diaphragm by another kind of sharp, I guess you would call it, area of a very dark shade that looks like free fluid to me. You can also see where the other two blue dots are above that white line. That is free fluid in the chest as well. So that's a good view there. In the top right, that is a subxiphoid cardiac view. So you see your heart chambers there, and see these kind of dark areas that are outside of this thick myocardium here, and that's indicative of pericardial fluid that could result in tamponade. And frankly, that much fluid probably is tamponade, but that's a positive cardiac window on a fast exam. So anyway, interesting pictures there. So you transfuse this guy. He gets a total of 2 units of whole blood, and he also gets his TXA. So his vital signs improve as well. His heart rate goes to 120, his systolic blood pressure is up to 138, and his respiratory rate cuts to 20. So he's GCS 15 when he comes into the ED. So a substantial improvement in his GCS. Now, whether or not that was a overworked, stressed intern marking it as 15 or not, I don't know. Maybe he was a little bit confused, but he was close enough to 15 to get a 15 in the official documentation. So he's obviously perfusing better after we've given him volume resuscitation. So he had a gunshot wound approximately 10 centimeters inferior to the right costal margin, so pretty far down, and 6 centimeters lateral to the midline. So he was like right over where his appendix would be, really. So the patient was taken to the operating room, and he survived to stay as well. So I think that's another big win. So this guy was a motorcycle injury, 34-year-old male, high-speed motorcycle collision. No idea what happened. Just call came in for a motorcycle crash. There was a jacked up bike and a person laying on the side of the road. He was in obvious distress. Heart rate 142, systolic blood pressure was palpated at 76. His respiratory rate is 28. His GCS is 7. So this guy's got evidence of severe head trauma. He's got evidence of broken bones in essentially all of his extremities, but you also note that he is bleeding profusely from a right lower extremity wound. This is the X-ray in the ER. Obviously, this guy has probably not learned his lesson on a motorcycle or an ATV or something like that before. If you notice the hardware in his lumbar spine, so maybe trauma is a chronic disease. But the radiology report read there is marked widening of the pubic symphysis, measuring in approximately 3.4 centimeters in transverse dimension, consistent with symphyseal diastasis, so consistent with open book pelvis. If you see these two wings here down at kind of the pubic symphysis here, there's a lot of space right there. That is abnormal. That should not be that wide. So this guy was pretty jacked up and likely had a bunch of pelvic bleeding that led to significant hypotension. So in the ED, so he gets an appropriate tourniquet from you guys, right? He's going to get TXA. He's got a big gaping bleeding wound that you're probably going to pack with combat gauze or some kind of hemostatic agent, right? And you're probably thinking about doing an intubation. This guy's jacked up. His GCS sucks. GCS less than 8, intubate, right? But before we do that, as we're preparing it, we resuscitate before we intubate, right? So this guy's vitals sucked. If you intubated this guy in the back of the truck or on scene with vitals like that, he will die. If you're greater than 5 minutes away from a hospital, you've sealed his fate, right? So if this guy dies and does not make it to an ED where he can get a thoracotomy within 5 minutes, 10 for penetrating, but in this situation, this is blunt, so 5 minutes, this guy's toast. So appropriately, start to volume resuscitate this guy, right? So you apply your tourniquets, pelvic binder, no, probably not. You give your TXA, but you start early blood transfusion on this guy. What happens is as you volume resuscitate this guy, he's got his tourniquet on, he starts to improve. So his heart rate decreases, his systolic blood pressure jumps up a little bit, and now he's breathing a little bit better too, and his oxygen improves on a non-rebreather. So his GCS still sucks, but he improves it to the point where he's maintaining his airway and breathing on his own. So what you've done in this case is you've given this guy volume, you've improved his hemodynamics, you've avoided intubating an unstable patient that had the potential of killing him, and you've got him to the ED to where he can be resuscitated further. I couldn't find the guy's outcome. I don't anticipate it went well considering his spectrum of injuries, but the point is you gave him a shot by volume resuscitation. So I think that's where these things are particularly important. So pediatric trauma, again, just a little bit different. Not entirely different, but a little bit. So you've got an 8-year-old restrained driver in the passenger seat. The vehicle has significant side intrusion. The airbags are deployed. There was prolonged extrication, all these things. So a few caveats to his initial presentation. So kids, much like the next case that we'll talk about, they compensate really well. So there's more subtle things you have to watch for with this kid. So you assess him, the child's awake, he's like looking around, but he's kind of quiet. You touch his hands and feet and they're kind of cool. His cap refill's a little slow. His heart rate's 162. His blood pressure seems okay, right? 98/62 for an 8-year-old. His respiratory rate's a little increased and the SATs are final room air. He's answering your questions, albeit a little bit slow. And he's complaining of a bit of abdominal pain. He has no obvious external signs of bleeding. So there's a few subtle things, pieces of this puzzle are coming together, right? So his blood pressure does, by the metrics, look okay. It's borderline, but okay. His heart rate, 162, is not really attributable to stress, right? Not really attributable to pain. He doesn't have any significant obvious injuries that you can note. So something's starting to kind of come together here, right? His interaction is a little bit off. He's got a high energy blunt trauma mechanism with prolonged extrication. The kid's just compensating. So once all these puzzle pieces start to come together, you're starting to say, like, hey, this kid is doing kid things, right? They're maintaining until they don't. And so what we do here, so once this kid starts to kind of fall off the edge, right, we transfuse them. Obviously a little bit different than before. We estimate this kid's kilograms, whatever they may be, and we give him 10 cc's per kilogram of blood, and then we reassess. This is where, as we talked about, this is where your Breslotag, this is where PD-Stat and things like that pay dividends, right? When you've got a kid, you don't know how much he weighs, you don't know any of that stuff, but the parents on scene are able to tell you that he's 8 years old. You can plug 8 years old into PD-Stat, and it will give you your average weights, average like things of that nature for you to estimate the volume resuscitation for you. So again, the TXA in pediatrics not necessarily indicated for our 15 and below population per our protocols, but a consideration there. So all that to kind of reiterate, right, is kids, there's some subtle differences. The biggest differences are going to come in your assessment and their physiology. So paying attention to the kind of subtle changes there will really buy you time, because if you get a kid who's hypotensive and showing obvious signs of hemorrhagic shock, you've got a problem. You're late in the game. So massive GI bleed, starting to cut it a little closer on time, so I won't beat a dead horse here. But so essentially, this is the patient that's a known liver disease patient. He's having large volume hematemesis, and he's showing signs of hemorrhagic shock, right? So your interventions for these guys, again, in the setting of trauma, we don't want to intubate unstable patients, so we would like to resuscitate before we intubate. So we're establishing our 2 large bore IV access, or multiple points of access for this guy. This is a medical case where it would be very appropriate to transfuse whole blood for these patients. Again, large volume crystalloid's going to, if it's all you got, it's all you got. But it's going to affect your coagulopathies. It's going to make things worse, and particularly with these patients, as upper GI bleeds are also affected by pH, right? So we give octreotide in the hospital to help kind of do some vasoconstriction. But another thing that we do is give protonics. So that's a PPI that a lot of people take on a daily basis, and that helps with acid reflux. But what high-dose IV protonics does, or PPIs, is it will increase the pH in your gastric and kind of your GI tract. And because again, the acidosis, the acidic environment is one thing that inhibits clot production. So we give that to increase our pH and help from that standpoint. We give antiemetics to try to decrease kind of gastric motility, to decrease clot dislodgement, and we give these patients TXA. But that's a good medical case where a transfusion would be appropriate. So an OB hemorrhage. So we have a 34-year-old female that you show up to the house. She's 8 months pregnant. This is her 4th pregnancy or 3rd pregnancy. She's at 34 weeks. She's sitting on the bathroom floor. She's pale, diaphoretic, anxious. There's blood on her clothes. There's blood on the floor around her. Her heart rate is 132. Her blood pressure is 104/66. Respiratory rate of 24, SpO2 of 98% room air. She's having a lot of abdominal pain. So again, red flags, right? This patient's showing signs of distress. She is pale and diaphoretic, so she's showing signs of hypoperfusion, despite you looking at her blood pressure and saying, like, this is kind of okay, right? So what we do for our pregnant patients, same thing, right? We're focusing on volume resuscitation. We're focusing on having our 2 large bore IVs, having multiple point of access for resuscitation. This is the patient that's appropriate to give TXA to as well, getting to an OB capable center or whatever is most available. But this is also a patient where I would consider initiating a blood transfusion as soon as possible. This patient has the evidence of large volume losses from her GU tract, and this despite having some somewhat normal blood pressures, right? So why is she having a more normal blood pressure despite dumping most of her blood volume out, right? So yeah, exactly. So there's a physiologic increase in your blood volume. that helps you from that standpoint. So there's more to lose. But you also have a greater cardiac output, so you maintain perfusion for longer despite significant losses. You lose some systemic vascular resistance by peripheral vasodilation, so your heart's having to work less hard to pump more blood. You have a very strong sympathetic compensation in this, so your tachycardia and your vasoconstrictive efforts out in the periphery are also supporting your hemodynamics as you lose blood. And the uterus is the first vascular bed to lose flow. So what you might see in this situation is fetal distress before you start to see hypotension and actual maternal distress as well. So there's a number of reasons why our OB patients, especially further along in pregnancy, will compensate better than your average person. So key points with this case, or any case really with OB, is the amount of vaginal bleeding is always difficult to estimate, and it's always wrong. Like, no matter how hard we try, nobody is going to quantify this in an appropriate manner. But a good way to try to get an estimate is the number of saturated pads. If this is like a kind of a prolonged bleed, that's actually a really good, helpful measure or metric for the hospital to use. So if you can inspect the perineum to determine if like this is like clots or if this is like blood pouring out, right? So that people say, I have vaginal bleeding as a complaint frequently. Sometimes that means a little bit. Sometimes that means it is literally pouring out like a river. So actually getting a visualization of what you're dealing with is very helpful. So patients in shock from vaginal bleeding should be treated just the same using the shock protocol per our guidelines. We always consider a pregnant patient with serious vaginal bleeding as an ectopic pregnancy, a placental abruption, or something like a uterine rupture or something along those lines. So we always consider the worst. So all that to say, those are kind of some medical indications, right, of reasons to transfuse blood products in a pre-hospital setting. And these can make big differences because, as stated, just like the kid, this patient is going to compensate for longer. So to run through these real quick, our transfusion reactions. Typically, these are things that are not going to really be a problem for you in the pre-hospital setting, right? Unless you're doing critical care transport, you've had someone who's been transfused earlier in the process, and now you're getting them later in the game, and you're doing an interfacility or something like that. But if you're transfusing on scene, the odds of you having a transfusion reaction are low, but they're not zero, right? So they're rare. The most common is going to be pretty benign reactions, right? So this is like a mild febrile reaction, or at worst, like an allergic type reaction, like a type 1 hypersensitivity, worst case scenario, and anaphylaxis. Severe reactions in the pre-hospital setting are uncommon, as stated, but early recognition is critical. So we'll skip through these pretty quick. So TRALI, a transfusion-related acute lung injury. So this essentially presents to you as an acute respiratory distress. This is typically like 4 to 6 hours or something like that after the infusion begins, but this is one that can occur a little bit closer to the completion of a transfusion, right? So what you're going to see is acute respiratory distress, hypoxia, bilateral pulmonary infiltrates. So they'll sound crackly. They'll sound like a heart failure exacerbation. Again, rare in the pre-hospital setting. This is essentially ARDS, right? So back to the Nang lung that I think is a cool name. So what it was is when we first started doing large volume resuscitation for hemorrhagic shock in our Vietnam War casualties, we started seeing this kind of unexplained lung injury where the lungs filled up with fluid, couldn't really figure out where this was coming from. There were considerations at the beginning that this was some kind of chemical weapon or something, that some kind of weird bacteria in the jungle or something along those lines, but it turns out it was just a lung injury from large volume resuscitation. So led to more modern balanced resuscitation type strategies. So TACO, this is essentially a volume issue, right? So this is transfusion associated circulatory overload. So this is more common in folks with cardiac dysfunction, CHF, kidney disease, things of that nature. You want to be on the lookout for this in like elderly patients and things, people of that particular group. So what we see here, this is like a hydrostatic type push out, right? Versus TRALI, which is more of a cytokine-mediated reaction. This is more of just pure volume, so it behaves in the same way as a heart failure exacerbation. There's too much volume in the pulmonary vasculature, so the fluid leaks out into the interstitium. Again, typically this is more of a delayed reaction. This is 6 to 12 hours kind of post-resuscitation where this is showing up. The difference in these two, there's a lot of similarities, right? So the difference in these two is when you see trolley, a lot of times you'll get a hypotensive patient. In a patient with TACO, a lot of times you will see hypertension. So you'll see JVD, you'll see rales, acute dyspnea, the hypoxic respiratory failure, respiratory distress, and diffuse rales in both. But there's a few key differences that you'll see, and one of them being kind of their hemodynamic status. As a way to kind of differentiate, because to you in the pre-hospital setting without our lab testing and x-rays and things like that, these will look kind of the same. A more common one is an acute hemolytic transfusion reaction. So a lot of times this is due to ABO or some kind of incompatibility with the blood transfusion. That is why we give the low titer O negative whole blood as a mitigation factor against things like this. But essentially you see this patient become hypotensive, febrile, they get chills, so they start shaking, they're hurting their back, and they start to pee dark colors, right? So if you have a Foley or something like that in, the pee turns like tea colored, something like that, this is something that you would consider. So in the field, if someone's getting blood, if you're still giving them blood and they have one of these reactions, you start to notice some of the hallmarks of this. We're stopping the transfusion, right? And we're intervening appropriately. The hallmark of all of these is going to be stopping the transfusion, managing the airway, and managing hemodynamic status, right? A lot of the remainder of the intervention is going to be more of a hospital one. So a febrile non-hemolytic reaction, probably the most common of all the reactions, is essentially a person gets a fever, they get some chills, their hemodynamics are essentially unaffected, and there's not a whole lot to this. This is one that we kind of mitigate by either stopping or slowing the transfusion. If you were to encounter this, I would just recommend stopping it unless they are hemodynamically unstable and getting this for like an acute reason. But if the patient is stable, this is something you can just stop until you get to your more definitive system for intervention. These are uncomfortable. Patients hate it. They feel like crap, but not usually life-threatening. There are allergic reactions. People have type 1 hypersensitivities, so they'll break out in hives. They get itchy, they start to flush, and there have been instances, but rare, of anaphylaxis where they will go into full-fledged airway compromise and things of that nature. So to manage these, we're obviously stopping the transfusion, but this is one where you can give some Benadryl and typically make this better, and then manage anaphylaxis, obviously, as you would otherwise. So essentially the protocol recommendations here, if you run into any of these, is going to stop the blood transfusion. So we flush the line and we start some crystalloid solution behind it, particularly in a stable patient. We give 50 milligrams of Benadryl IV if this person is having one of those, if you suspect like a type 1 reaction. We can give Solumedrol, 125 milligrams via IV as well. And for the anaphylaxis type stuff, we would just treat them as we would otherwise. So to put all this together, a lot of words, a lot of things going on, but essentially when we encounter hemorrhagic shock, the big recommendations and where we're headed with this is we're going to limit crystalloid because our patients go into the lethal triad. Crystalloid, while giving you volume resuscitation, and a lot of times, seemingly helping from a hemodynamic standpoint, can affect us from a coagulation standpoint, worsen acidosis, and ultimately hurt our patients, particularly when blood products are available. We prevent hypothermia for the same reasons. We monitor for these reactions when they do happen, but they are rare. But blood is the thing that we need to be doing. It's definitive resuscitation. Blood out needs blood in. So bottom line, right now the military evidence is really strong. It shows that there are obvious mortality benefits when given early, and our civilian data are starting to confirm that and starting to show that this is a feasible thing for our systems to do. Now, it's expensive, it's logistically complicated, and each system and how they do it is going to look different. We had a couple of roundtable discussions at NAMSP in Tampa a week or so ago, and the way everyone who's doing this is doing it is different. We use our EMS supervisors. Some people have it on every truck. It all depends on your population size, your catchment area, and your resources. So it's going to look different for everybody. But the bottom line is that this stuff is saving lives. And we're starting to confirm that. So that's all I got.
Great. Thank you, Dr. Sullivan. We did have one comment online. It was about one of the cases that was pretty early in your lecture, but the open book pelvis.
Yeah.
And so they said, why wouldn't you use a pelvic binder to increase pelvic stability? So I actually get questions about pelvic binders pretty frequently because they appear in the literature so much. If I'm honest with you, I've never put a pelvic binder on a patient in my entire life. I don't think I've ever seen a commercially produced pelvic binder, but I know we have agencies in Central Alabama, a few agencies that are carrying them, and they seem to be really emphasized in some of the national EMS literature. So what are your thoughts on the pelvic binder and its utility in pre-hospital?
So these are my thoughts, and this may make Dr. Ferguson sweat, but I'll give them to you anyway. So I think in regards to a pelvic binder, if you are going to have a patient to a definitive care facility within like 15 minutes, there's probably not a whole lot of utility. Even if you're clamping the pelvis down, right? There's still a lot of blood volume. There's still a lot of space in the pelvis that blood has to fill in order to tamponade itself. If it's an arterial bleed, it's even more, right? If it's a venous bleed, yeah, maybe. But an arterial bleed in the pelvis takes a lot of pressure to tamponade. And how much benefit to you cranking a pelvis down, potentially shearing bones together, potentially causing more vascular injury? How much benefit are you going to get from that standpoint? Now, if you are at, like, say this trauma, that I'll say this anecdotally, the times that I've seen a pelvic binder recommended by a trauma surgeon and used is, say the patient is coming from Aniston or DCH, where there's going to be a longer transport time and they have a wrecked pelvis. At that point, maybe there is enough time for the blood to accumulate to a point where a tamponade strategy might be effective. And so I've seen them recommended by experienced trauma surgeons in those settings before, and maybe given the more prolonged nature of that transport, and therefore more time to actually develop some tamponade physiology or something like that in the pelvis, maybe they're more useful. But again, there are plenty of commercially available, and there's some cool ones out there, and it makes sense. But in reality, like if you're going to be at a hospital in a few minutes, I probably.
Yeah, I agree with you. I think that's all good. I think that people need to realize the point of pelvic binders to tamponade the blood and try to control the bleeding, and how effective that is, and the times. From what I can tell, is primarily a guess at this point. I'm not seeing any great research at a hospital setting to do that. So you referenced a lot of great research. Really appreciate that. We just wrapped up 6 months ago or so the Tower trial, which was a national trial which helicopter crews in this area participated in, and it was really comparing whole blood in the presence of traumatic hemorrhagic shock versus whatever their standard of care was. So for some people that was blood components, for other people that may have been crystalloid fluids. I think that debate's going to rage on for a while because there's some inconsistencies there in the way we think about fluid resuscitations. And I would also add that you rightfully talk about how our military combat experiences have shaped some of this. I would argue that probably the mass shootings in the United States over the last 25 years have shaped the interest in this topic even more than the battlefields have. But the rub is National Association of EMS State Officers publishes a national EMS guideline that's a primary document used by item writers at the National Registry, by the way, so people have to pay attention to it if they want to pass that test. And those recommendations are very strong and rigid. They pretty much say in the presence of hemorrhagic shock without traumatic brain injury, you give blood, or if you don't have blood, you give components. If you don't have components, they say give nothing, that crystalloids are actually contraindicated. And I see where they're coming from that, but then nobody's really comfortable in real life, right? Because most of the ground units in this area still just have crystalloid fluids, the vast majority. So you're going to have a patient bleeding to death in front of you, and you're not going to give any IV fluids. Seems very, very odd. It makes our eyes cross a little bit. And maybe that's where we're really headed to in practical practice. But I think it's a little unreasonable to ask people to do that now. And I don't, the evolution of the studies has been, is blood safe? Yes. Does blood help versus blood products? Does blood help versus crystalloids? There's been we've done tons of studies on, is it 1-to-2 ratio? Is it 1-to-1? Is it 2-and-2? Is it 2-and-2-and-2? Is it 1-and-1-and-1? So each one of those has had separate studies, and then we've had a bunch of meta-analysis of those studies over the last 25 years. And really everything to me points to whole blood, and we really can't even explain why whole blood seems to have so much better outcomes than the components. But it seems to me, looking at the data, others might disagree. What do you think about, you got normal saline, you're 25 minutes away from trauma center, and you give it to them? How much do you give to them?
I guess that
death in front of you.
Yeah, so my initial thought of that is essentially like the same kind of, I guess the same reason that some of the data doesn't show as much of a pre-hospital benefit when you have a rapid transport time and you're going to be in the trauma bay pretty quickly. I'm wondering how much benefit, like how much saline are you going to get in there anyway if you're a very quick transport time to the hospital?
You would be surprised. We used to, on a regular basis, get about 1 liter per block of travel.
Yeah. And then like how much benefit are you doing with that liter versus
how much
damage? Versus downstream effects of coagulopathy as they go into the trauma bay and as they go into the operating room. That's the question. And I agree. It's like when you only have that, it's hard not to do something about a patient that's in shock.
I mean, I guess the typical rule of thumb for a while, since we first embraced permissive hypotension, the rule of thumb has been titrate to a peripheral pulse, which is fairly inexact, but it's practical. And I would also say that the big caveat to all of it is, to me, if they have a traumatic brain injury or evidence of rising intracranial pressure, all bets are off. You got to maintain a blood pressure, or that's going to kill them. So now we're really going down multiple decision trees, right?
Right.
We're asking people to figure out a lot in a environment that has very few definitive answers.
So you're saying the answer is it depends.
Yeah, I think it really depends. And so yeah, I mean, I think it's a great advancement for us to have the whole blood. And I think that we should give whole blood instead of the crystalloid fluids and hemorrhagic shock, whether it's trauma or not. But I think that the vast majority of EMS providers in the state don't have access to blood right now. So I think what our concentration should be would be getting more blood to more people in the field.
Yeah, agreed. Cool. Well, great lecture. No time's running out. So just on that note, I know some of y'all are aware that we applied for a DOT grant to do a planning to look for regional whole blood in 9 counties in the state. We did get that grant. It's a planning grant. The hopes that we can get that going in the next few months. And then if we can get a good plan, then the DOT will support the funding of the implementation of that grant. So we shall see. But we know at least in the Brems region, we've got 7 agencies now that are doing blood, component or whole blood, plus AirMed. In the state, there's several others. So it's a great way to move forward. With the transfusion reactions, I would say that just if you are carrying blood, one of the biggest things you're going to have to do is make sure you store that appropriately and document that. because transfusion reactions are rare, but the one that would get you would be is if you let blood sit out in the back of an engine or a rescue and get too hot, then you lose that resource, that blood's no good, or if you give it, someone has a very bad outcome because of that. So just be safe with the blood products. But we are in Trustful in 2 weeks in the Helena area. We're fixing to do some lunch and do skills labs to come out. Should have a cadaver lab again end of April or end of May. And I'll put that out on Facebook and Eventbrite when that comes into play. And I think that's all I got. I'm not sure where we are in March. I have to go back and look now, so I can't remember. But Trustful in 2 weeks. So,
that's right. Thank you, Dr. Ferguson. Thanks, Dr. Sullivan. So if you're participating with us here in person, make sure you scan the QR code that we'll have up on the screen here in just a minute and fill out an attendance form. We'd love to get your feedback. We want to get you your certificate. If you're listening online, the link is in the Q&A section for the attendance form. The password for the attendance form today is the word transfusion. Please don't hate. I'm not the one that put the password on there. That's way too many letters for me, but that's what it is. It's transfusion. Also, if you've had trouble getting certificates, please let us know that by sending an email to certificates@emschallenge.org. If you're trying to get a certificate for day and nothing that I just said works for you for whatever reason, you can always send an email to alabamaemschallenge@gmail.com, and it will give you an automated response with a link to the attendance form. Thanks, everybody, and we will see you next time.